Good morning, good afternoon to everyone. Thank you for joining us for the Marquis MedRec Collaborative Informational webinar. The webinar today will be presented by Dr. Jeffrey Schnipper, who was the PI for the larger MARQUIS1 and MARQUIS2 studies. And with that, Jeff, I'm going to hand it over to you.
Excellent. Thank you, Sarah, and thank you so much for all of you attending. I'm really excited to talk to you about the work that we've been doing and the work that we're going to continue to do and that we hope that you'll be a part of to work on medication reconciliation. As Sarah said, my name is Jeff Schnipper. I'm a hospitalist at Brigham and Women's Hospital in Boston, an associate professor at Harvard Medical School. I've been working on medication safety during transitions of care research and quality improvement for about the last 15 years. It's been a real pleasure to do a lot of this work with the Society of Hospital Medicine. They've been tremendous collaborators and colleagues and champions of this. And I think we have a really good product at this point after a lot of research, and we hope that a lot of you will take advantage of it. So when you go to the next slide. So here's our agenda, and I do not plan on speaking for more than 30 minutes. We'll have plenty of time for questions and answers. So first, I just want to give a brief intro to the Society of Hospital Medicine and the Center for Quality Improvement. We'll talk briefly about why medication reconciliation is important for patient safety. We'll talk about the first and second MARQUIS studies, and then introduce what's in the Marquis MedRec Collaborative and why you should join it. Some concrete details about how you should sign up. And then, like I said, hopefully we'll have plenty of time to answer your questions. So next slide. So first of all, just a word on SHM and the Center for Quality Improvement. And some of you may know this, but I just wanted to make sure that we level set. So the Society of Hospital Medicine, as you probably know, is the first and only national organization for hospitalists. They lead the transformation and improvement of care for hospitalized patients through innovation, collaboration, and action. They currently have 16,000 members and growing. One of the unique features of SHM, I would say, is their focus on quality improvement. They're not just an advocacy organization for its members. They're not just protecting its members' market share, but really are trying to transform healthcare. And the Center for Quality Improvement is one of the ways that they do that, probably the biggest way that they do that. So next slide. So SHM's Center for QI has a number of different projects, as you can see. So IPASS, which is focused on handoffs of care within the hospital, so things like sign out. MARQUIS, which obviously we'll talk about. Glycemic control, and BOOST, which is all about improving transitions of care much more broadly. And as you can see, between and among these different projects, SHM engages hundreds of hospitals throughout the country. And you can see some hospitals on more than one of these specific projects. So, pretty broad reach and a lot of experience in doing QI work. Next slide. So mentored implementation is one of the major ways that they spread their work. It's a proven method to spread best practices to a large number of hospitals. And the way it works is that you have a trained mentor who works with the local quality improvement leaders from each site. So the local leaders are the mentees, and they have regular interactions, often monthly phone calls, often additional on-site visits. And they provide a number of things. I think first and foremost, probably accountability. If you know you have to get on a call with somebody every month, hopefully you'll have moved your project ahead a little bit. You got to answer to somebody. Content and quality improvement expertise. The mentors that we work with are trained and have a lot of experience in knowing both the content, so for example, glycemic control or transitions of care, but also how QI really gets done on the ground level. And then they provide individualized guidance regarding implementation. They help troubleshoot, identify barriers, help you manage barriers, give constant feedback on progress. So how are you doing with your processes of care? How are you doing with your outcomes? What needs to be iteratively refined? Are you ready to spread your interventions? Are you ready to sustain your gains? And then finally, they just provide an outside voice of reason, someone who's not embroiled in your local politics, who can, sort of step back, give the 20,000-foot view on how you're doing and how you need to go forward. And SHM has been recognized from the National Quality Forum and the Joint Commission, and was given the John M. Eisenberg Award for Innovation in Patient Safety and Quality at the national level for their mentored implementation approach. So next slide. So let's switch gears and talk about why med reconciliation itself is important. So next slide. So adverse drug events, which are defined as any injury due to a medication, are an epidemic patient safety problem. And when I say due to a medication, I mean that pretty broadly. So it could be side effects from a med, it could be injury due to overuse of a med, underuse of a med, or misuse of a med. And ADEs are estimated to occur in 5 to 40% of hospitalized patients, and in 12 to 17% of patients in the 30 days after hospital discharge. Next slide. So we know that transitions of care, so for example, going into a hospital and then leaving that hospital, are vulnerable times for patients when it comes to medication safety, because we make multiple medication changes, right? The average patient has about 40% of his or her medication regimen rearranged by the time they leave the hospital. The discharge process itself is often a rushed event, as any of you who are hospitalists know, and we often do not provide adequate time for patient education. And then there's discontinuity of care, right? You're handing the care back to another group of providers. There's that information voltage drop. There's often inadequate follow-up. And so one of the things that happens during that transition are medication discrepancies. And so these are unexplained differences among documented regimens across different sites of care. So patients come into the hospital on one medication regimen, they're on a different one in the hospital, and a different one when they leave, not because of clinical reasons, but because we make mistakes in this whole process. So next slide. And when we think about medication discrepancies, there's really two main causes. And so the first one are history errors. So we don't even know what medications the patient was taking and was supposed to be taking when they get admitted to the hospital. And so, for example, we don't even know the patient was taking aspirin. Therefore, we don't record it on our med list. We don't order it at admission. We don't order it at discharge. And this is not our fault. Sources of information we get are inaccurate. They're out of date. They're unavailable. And even when they are available, sometimes we have the lack of time to access them. This is not an easy task. And then the other reason why discrepancies occur are reconciliation errors. So the orders are wrong, even though the history is right. So, for example, we may know that the patient was on aspirin. We put it on the pre-admission medication list. Maybe we hold it on admission for a good clinical reason, like they're bleeding, but we forget to restart it at discharge. Or we forget to switch the short-acting med back to the long-acting med, or the med that is on formulary in our hospital with the med that is actually covered by their insurance in the same class. And this happens because we have lack of access to pre-admission medication lists at the time that we're writing the orders for the next segment of care. Sometimes they're just clerical errors. This problem, needless to say, is more common at discharge than it is on admission. Right, at discharge, you've got to look at both the pre-admission meds and the current meds and create that coherent list. And this is a common time for mistakes to occur. Next slide. So in theory, medication reconciliation is the way to minimize medication discrepancies. And I like this particular definition of MedRec, which is a process of identifying the most accurate list of all medications a patient is taking and using that list to provide correct medications for patients anywhere within the health system. And this definition is from the Institute for Healthcare Improvement. And I like it because the focus is not on creating the list or checking the box or meeting a regulatory requirement. It's about getting the meds right as patients move within the healthcare system. It's about patient safety in the end, and MedRec helps get you there. Next slide. So what does MedRec involve? It's got a number of steps to it. The first one is taking a best possible medication history, a BPMH, and that term was coined by Ed Etchells in Canada. It sort of acknowledges that we may not always be able to get it perfect, but we need to try as hard as we can to get it as close to accurate as possible. You then write orders based on that medication history. You have to compare regimens across transitions. So how did that pre-admission regimen compare to that current inpatient regimen, compare to that discharge regimen, and make sure that you haven't made any mistakes. Update lists and orders as more information becomes available. Identifying and correcting discrepancies across these different settings of care. Communicating with patients, how is your new regimen going to be different from the one that you came in on? So what meds are new, what meds have changed, what meds have been stopped, and then communicating with the next providers and the next sites of care. So how has the regimen changed? Why did the regimen change? What now do you need to watch out for? And make sure that's clear for the next providers who are going to be taking care of that patient going forward. Next slide. So let's talk about the MARQUIS-1 and MARQUIS-2 studies. Next slide. So the goal of MARQUIS-1, and MARQUIS stands for the Multi-Center Medication Reconciliation Quality Improvement Study. So the goals were to develop a toolkit of best practices for medication reconciliation, conduct a multi-site mentored quality improvement study, assess the effects of these QI interventions on unintentional medication discrepancies with potential for patient harm. These are a type of potential adverse drug event. And then conduct rigorous program evaluation to determine, first, the most effective components of this MedRec program, and then two, how best to implement these components. Next slide. So we did use a mentored implementation model. As I mentioned, it's been done for many other projects conducted by SHM, and we worked with SHM with this study. So each site had a local champion, so they were leading their local QI team, and they were the mentee, the recipient of the mentorship, and then they developed their QI team from there. We had a mentor, so it was a physician with quality improvement and med reconciliation experience. They had monthly mentor-mentee calls. They had 2 site visits over the 18-month study period, and SHM provided project management and data analysis support. So making sure that meetings actually happened, calls actually happened, feeding data back to the sites, a library of documents and best practices, milestones, all those things. Next slide. So in MARQUIS-1, 3 out of the 4 sites improved their potentially harmful discrepancy rates. And we had a pretty rigorous process for determining these discrepancy rates, which I'll get into shortly when we talk about MARQUIS-2. Interestingly enough, and I don't want to get too far afield, the one site that did not improve, the main thing they did during the implementation period was adopt a new electronic medical record, and their discrepancy rates went sky high, like a 3- or 4-fold increase. And it's a cautionary tale about what happens when you implement a new vendor electronic health record. Nevertheless, even despite that, implementation of the intervention was associated with a significant improvement in total medication discrepancy rates over time. So 9% reduction in discrepancies per month, every month that they were involved in the study, over baseline trends and compared with control units. And 3 intervention components seem to be the most associated with significant reductions in potentially harmful discrepancies. So when these different things were adopted across the sites, this is when we tended to see reductions in discrepancy rates. So the first was hiring additional staff, which usually meant pharmacists, to assist with discharge medication reconciliation and with patient counseling, training existing staff to do those same 2 tasks, and clearly defining roles and responsibilities among clinical providers. So what's the job of nurses, what's the job of pharmacists, what's the job of physicians, etc. Next slide. So we learned a lot of lessons from the first MARQUIS study. First of all, we found that it was insufficient to just teach providers how to perform a BPMH and assume that they were then good at it. Like a lot of things, you actually need to test them on their competency. It's a skill, and so that skill needs to be acquired, and some people take more time than others to acquire that skill. We found that BPMH training was most effective as peer-to-peer, so pharmacists teaching pharmacists, physicians teaching physicians, so the trainer could model the work directly. Some hospitals used decentralized pharmacists, so unit-based pharmacists on the wards. Others used centralized pharmacists, often in the basement where meds were being dispensed. Each has its advantages and disadvantages. So a centralized pharmacy group could be deployed as needed to the highest risk patients in your hospital, so it's very efficient. However, if I had to choose, I would say the unit-based pharmacists were actually more successful. They were up on the floors, they knew the patients, so the activation time to get to know a patient to provide discharge counseling or discharge medrec was very, very low. They could just swoop in there because they already were familiar with the patients. And also just logistically, there's not a lot of time between when discharge orders are written and when patients are discharged, but a pharmacist on the wards could very easily get there in that limited time period and start doing things like discharge medrec and discharge counseling, while deploying a patient from someplace else might take too long. The patient might already have been discharged from the hospital. They could also do a lot of other things around medication safety aside from medrec because they were up on the units. Public relations campaigns can be really effective in changing attitudes about medrec. So I think a lot of people still think of medrec as a regulatory requirement, and that's unfortunate, and it's an accident of history. The term was coined at the same time that it became a joint commission requirement, and so a lot of people still think of it in those terms instead of thinking about it as a patient safety imperative, right? We are all responsible for the orders that we write and the medications that patients take. It doesn't mean we have to be involved in every step of the process, but we have to make sure that that process works, and I think that's the message that needs to get out there. It's important to make roles and responsibilities explicit and to hold stakeholders accountable. So each each role has a part to play in MedRec, and they have to know what that role is and know what everybody else's role is, and to be held accountable for that. And then finally, improvements in health information technology are possible, but they're a slow, iterative process. Next slide. So having taken all the lessons from Marquis 1, we then applied for another grant from AHRQ to do Marquis 2. And again, SHM was our co-investigators in this work. And the question was, all right, so Marquis 1 worked, but can we take all these lessons learned and make it even more successful? And so the aims here were to implement the refined Marquis evidence-based medication reconciliation toolkit at 18 diverse hospitals now, so a lot larger spread, using a mentored implementation quality improvement model, to rigorously evaluate the effects of the Marquis program on unintentional medication discrepancies, and then to inform future spread of medication reconciliation interventions by performing an evaluation of program implementation using the RE-AIM framework. So this is sort of the study of the study. And again, what can we learn about how to make this most successful in the most number of places possible? Next slide. So we had 18 sites in total, 6 sites in each of 3 waves that were offset by about 4 months. We selected these 18 sites from 72 applicants, and we picked the sites that were the most ready, willing, and able to take on this work, because it is work, and there's no point in investing, our time and anyone else's time if there isn't institutional support for the work to be done. And we purposely chose sites that varied by size, academic affiliation, geographic location, and use of HIT. Generally, they targeted adult patients on medical and surgical wards. We haven't done a lot of work in MedRec on children, but we should in the future. And then we obviously targeted the hospital staff involved in the MedRec process. So residents, attendings, nurses, pharmacists, nurse practitioners, physician's assistants, pharmacy technicians. And again, it was a mentored implementation project over 18 months. This time we did 1 site visit per hospital. Next slide. So here's the main components of the MedRec toolkit. So everything on the left is about the MedRec bundle. It's the activities that ideally every patient should receive. And so they include taking that best possible medication history, reconciling meds at all points of transition, but especially at discharge, which is the highest risk transition, because now the patient's about to go home and be less monitored. And it may be a while until any errors are fixed or corrected or even identified. Patient counseling at the time of discharge, and then forwarding the medication information to the next provider of care. Again, how are the meds different? Why are they different? What do you now need to watch out for? Part and parcel with this bundle is risk assessment, right? So standard risk patients should get a standard bundle. High risk patients should get a more intensive version of that bundle, maybe using pharmacists, maybe taking more time. And then obviously you need to train providers in how to do these components, especially how to take a BPMH and how to do discharge counseling. Those are the things that they probably may not be so familiar with. So everything on the right-hand side of this slide are sort of the other things other than the bundle. So 1, improving access to pre-admission medication sources. So can you encourage patients to own their own medication list, right? If every patient came into your emergency department with an accurate, up-to-date medication list in their wallet, that would solve a lot of this problem. And so how do you get there? And then how do you facilitate access to other medication sources? So local community pharmacies, local outpatient practices, other sources of data. And then finally, there's the other high-risk, high-reward interventions. So things like implementing and improving health information technology around MedRec, especially improving vendor systems that are now in existence in most of our hospitals, utilizing social marketing, and engaging community resources. And I can talk about those a little bit more detail during the Q&A if you are interested. Next slide. So the primary outcomes in Marquis 2, the first one was unintentional medication discrepancies. And so the way this works is that we trained study pharmacists at every site to take a gold standard medication history using all available sources. And we use a number of tools to get everybody to do this really, really well. And then they compare that gold standard to the inpatient team's pre-admission medication list, to the admission orders, and to the discharge orders. And if there's a discrepancy with the admission or the discharge orders, then they have to figure out why. So if the orders are wrong because the team's pre-admission medication list is wrong, well, that's a history error, and you're basically done. If the orders are wrong, even though the history was right, well, then the question is, was it intentional or not? If it's intentional, then fine, there's no error, and you don't count it. If it's unintentional, well, that's a reconciliation error, right? The orders are wrong, even though the history is right, and they didn't do it on purpose. And so sometimes you can figure that out from the chart. Sometimes they have to go back and talk to the clinicians and say, hey, did you really mean to do this on purpose? And then they categorized all the discrepancies by timing, so admission versus discharge, type, so omission, additional med, dose discrepancy, frequency discrepancy, and then reason, so history error versus reconciliation error. And this method is identical to the new metric of medication discrepancies of MedRec quality that is now in place at the National Quality Forum and by Leapfrog. So if you are a Leapfrog hospital, chances are you've been asked to collect data and to measure it in exactly this way over the last year. We now have hundreds of hospitals that have been doing it as part of Leapfrog. Next slide. So, and then there's the program evaluation, as is sort of the study of the study. So we use the RE-AIM framework, which is ideally suited for stuff like this to inform future spread of interventions. So RE-AIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So Reach is the number and representativeness of the sites that applied, the sites that actually were chosen to be in the study compared to all hospitals that are out there. Effectiveness, well, those are our outcomes, right? So the number of unintentional medication discrepancies in admission and discharge orders. Adoption is about the number and characteristics of the units and the services that adopt and don't adopt your intervention. So is it just medicine services? Was it surgery? Certain units in the hospital versus others. Implementation, so these are the number and types of intervention components that were adopted over the course of the study. And then finally, there's maintenance. So looking at all the primary and secondary outcomes over time. And one of the things that we did in MARQUIS2 is we looked, all right, 6 months after mentored implementation ended, were they able to keep these interventions going? Because you can do all this work to get something up and running, but if they don't sustain, then you lose most of the benefit. We had a patient family advisory council, and they provided the patient perspective throughout the study, especially the patient-facing intervention components, so things like discharge counseling, public health messages, did we get the messaging right? Community engagement, how do we engage with communities and send out messages like, you need to keep an accurate medication list with you at all times. And then we had a stakeholder steering committee, and still have one, with representatives from the National Patient Safety Foundation, which has now merged with IHI, with the American Society of Health System Pharmacists, which is the parent organization for hospital-based pharmacists, and then the Joint Commission, which of course was the one that started all this work with their mandates and their national patient safety goals. Next slide. So what are the preliminary results of MARQUIS2? So really high rate of adoption. All sites implemented at least 2 components, and the majority of our sites have implemented at least 9 components. And actually we have 8 sites out of the 18 that hired new staff, usually pharmacy technicians, to take best possible medication histories in the emergency department of patients who are being admitted upstairs, which is pretty impressive considering how hard it is to get hospitals to hire new staff to do anything in this day and age. So the fact that almost half of our hospitals actually hired new staff, I thought was pretty impressive and sort of a testament to the amount of institutional support that they had, but also the case that we were able to make why they needed to hire that additional staff. The most commonly implemented components were training dedicated people to take a best possible medication history. So all 18 sites did that. 16 of the sites identified high-risk patients. 15 of the sites reallocated staff to take a BPMH, and 15 sites also clarified roles and responsibilities among staff. So across all 18 sites, the average reduction in discrepancies is 37%. No site had less than a 10% reduction, but we have some sites that were in the mid-60s, so 66% reduction in discrepancies, which is pretty impressive. And in terms of lessons learned from the first MARQUIS study, I would say the things that probably led to the most success in MARQUIS2 were, 1 was rigorous site selection, 2, doing the site visit earlier to get institutional buy-in that much sooner, more rigorous training and taking a best possible medication history. So we have all these test cases now where we can certify competency. We've done a lot of work with train the trainer. So how do you train your local pharmacy leaders to train other people in how to take a BPMH? A lot of webinars and workshops on a variety of topics when we ran around the country doing workshops, and then the involvement of our Patient Family Advisory Council. Next slide. So that takes us to the Medication Reconciliation Collaborative. So next slide. So the question is, can we take this toolkit and all the lessons that we've learned over the last 5 years and spread these kinds of gains to even more sites? And the other question we were asking is, can we take the best of mentored implementation but do it in a lighter weight, more scalable, read less expensive way, less expensive for you, less expensive for us. So, can we still have accountability? Can we still have timelines and milestones? Can we still have expert opinion? Can we still have a collaborative community? Can we still have measurement tools, simulation materials, all of those things, even if you don't have like a monthly call with a one-on-one mentor? Next slide. And so the idea is that I think we've achieved this, and this would be the third wave of sites that are joining the collaborative. So we have designed a 14-month intervention period where you get access to an online collaborative community through HMX, which is the online collaborative community that SHM uses for a lot of other topics as well. So this way you get to share ideas, ask questions of the other sites. There's a library of all the documents that you need, but it's still secure. So you can learn a ton from each other. All the tools and resources that you need, as I said, a lot of work has been done recently on Train the Trainer, on videos, on cases, on simulation. Monthly office hours, so every month, as many sites as want to call in, and I basically host virtual office hours, and we check in with every site and we see how things are going, and we answer questions and we troubleshoot issues and we share issues with each other. Everyone else, meanwhile, is listening in and learning from everybody else's experiences. Data collection tools and training, and we've made this much easier. Now we have a very fancy Excel spreadsheet where you collect your own data on medication discrepancies, and it automatically graphs the results over time. You can see the results of the intervention patients versus those who didn't get interventions. You can see which kinds of interventions were most effective. So it's pretty powerful. You can get statistical process control charts that graph your progress over time. And we provide training on how to complete all of this. And then we have a suite of quarterly webinars. So we tackle a number of topics. How do you get institutional support? How do you make the case to your C-suite why they need to invest? How do you train other people to take a best possible medication history? How do you improve your local health information technology? How do you sustain your gains? How do you spread your gains over time? Next slide. So here's an example of the HMX community. As I mentioned, there's a discussion board. There's a directory of colleagues in the program. There's a library of files, all the tools and resources that you need. Next slide. So here is an example, a screenshot of some of the milestones. So you can track your own milestones over time to make sure that you've got the 20,000-foot view in mind. Where should you be heading over those 14 months, even while you're sort of embroiled in some of the more finer details. So we organize the timeline by phase. And then we've got site assessment tools. You can do your own self-assessments of how ready you are to change. A charter, which often is really useful for getting your buy-in from the C-suite of your hospitals. And then all the materials around the intervention components. So defining roles and responsibilities, training materials, standardized cases, HIT improvement guide, social marketing materials. How do you get those messages out there to the public around their roles in medication reconciliation? Like I said, things like keeping an accurate medication list with them and taking it with them wherever they go. Next slide. So the monthly office hours, so sites bring questions for program leaders, provide a brief update on their progress, learn from each other. We record these, and you can listen to the recordings through HMX. We also take notes, and those are also available on the HMX website. So anyone who misses an office hours call can still benefit from the conversation, even if they couldn't contribute to it. Next slide. So we do a data pharmacist training webinar between months 2 and 3, which is about the time usually that sites have identified who's going to be their study pharmacist, who's going to be in charge of data collection. So we teach them the protocol for measuring discrepancies, how to collect the data, how to record the data using our data collection tools. And as I said, the graphs are automatically produced when you fill in the data in the Excel spreadsheet. And then how to interpret and use that data to inform interventions and assess progress. And again, this is something we can always talk about during our monthly office hours. I've also done additional individual phone calls where needed to help sites interpret their data, how to explain it to their hospital leadership, how they can use it to motivate further action and further resources. Next slide. And as I mentioned before, here's some of the quarterly webinars that we do. So we have a kickoff webinar. We do one on the data collection, one on overcoming barriers to implementation, a train the trainer session on history taking, one on discharge counseling, one on improving MedRec HIT, and then finally one on sustaining your gains. Next slide. So at this point, you're probably asking yourself, how can I apply? Because this is awesome. So you go to hospitalmedicine.org/MARQUIS-collab, click on apply, download the PDF. I suggest that you sort of prepare the application in advance, and then you can go to the online application and answer all the questions as you prepared them. That's probably the easiest way to do it. There is a nominal fee of $4,700. Nothing comes for free, right? So we have to pay for these resources and the time of the folks who lead the effort, including mine. The other thing that I would say is that sites that buy into this and know that they have to pay some money for this in some ways are the ones that are the most invested, because they say, well, we just spent all this money. We got to make sure that we get our money's worth. And so it actually can be a motivational tool for your site, and it proves that your site it actually has institutional commitment to doing this work. So I actually think it helps with buy-in in a lot of senses. Next slide. So I think that's it. As promised, a half hour. So why don't I stop there and open it up for questions? And Sarah, is there a way for you to unmute everybody? Are they supposed to use the chat function within the webinar? You tell me what the best way to do this is.
So if you have a question, there's a little hand icon next to your name. If you click on that, that'll be the equivalent of raising your hand, and I'll be able to individually unmute people. Or there's a question box, and you can just type out your question, and I'll read it.
Perfect.
So. Okay, it looks like we do have a question from, oh, my apologies. All right, so this comes from David. Excellent tools for discharge and MedRec. Could you please describe what tools and deliverables are available for internal transfer of MedRec?
That's a great question. So yeah, so we've definitely focused most, if not all, of our efforts on the admission and the discharge. But you're right. I mean, MedRec also needs to happen during an internal transfer in the hospital. I would say almost all the tools that we use at discharge are applicable to transfer. I mean, you have to compare the pre-admission med list with the current med list and generate a coherent set of, in this case, transfer orders. That's a great time for pharmacists to get involved in high-risk patients to make sure that it's done correctly. You don't need to do patient counseling at that time, obviously, but sort of those med-rec pieces are probably pretty transferable. I would say over time we probably will develop some further tools. I think it's probably more important that there's policies in place at your hospital that says that that's a time where you have to do MedRec well, and then, like I said, probably getting someone involved in your highest risk patients during that transfer, because a lot of things can go wrong at that moment. Especially if a patient is going from the intensive care unit to a regular floor, it's very possible that no one took a good medication history when the patient was first admitted, and so now is the time where you actually have to do that good history. And make sure that they're on the right stuff as they're coming off the out of the ICU and onto a regular floor. So, but great question. Thank you.
So our next question is, for the sake of the collaborative, who owns the data collected during the project, the hospital or SHM?
That's a great question. You do. We are, this is not a study. This is a quality improvement effort. So the data is yours. You can use it as you see fit. You can give it back to your hospital leadership. In terms of publication, if you ever wanted to write stuff up, I think we would just ask for you to stay in touch with us and figure out how best to do that. And I can certainly help out, in showing those results. But unlike the studies we've done where it was clear that the main results were going to come from the central site, you own the data. And even in MARQUIS2, if sites had individual site-level data that they really wanted to publish that was fundamentally different from the stuff we were publishing across all 18 sites, then we have let sites do that as well. I hope that answers that question. If not, just please ask it again. But the data are yours.
All right, so our next question comes from Regina. We have a program in place that is very similar to what you are discussing. Is this usually for hospitals that don't have a program yet?
We will meet hospitals wherever they are. And I would say we've had hospitals that have started essentially from scratch. We've had hospitals that have had pretty well-developed programs and still found room for improvement. What I would say is that if you already have dedicated history takers, this is a perfect opportunity to see how good a job they're doing. If you don't have someone already doing a gold standard history and comparing it to the ones taken by the folks in real time, this is a good opportunity to do that. If they're already doing a fantastic job, then I think the issues are, all right, how do you spread that to as many patients in the hospital as possible? How do you get it to patients who may not have gotten it? Maybe they were a transfer from another hospital or a direct admission. How do you sort of spread and sustain your gains? On the other hand, if they're not doing a perfect job, then this is a perfect opportunity to do some feedback, to do some additional training, to improve that. We've had hospitals where they really had that whole process really down, and so for them, the focus was much more on the discharge medication reconciliation and the patient counseling, especially in high-risk patients, and we're still able to make tremendous gains. If you're doing all of those things, maybe there's a little less to gain from the collaborative, but I think there's still some social marketing, community engagement, improvement in your technology, or you move on to the post-discharge setting. What do you do to prevent readmissions even much more explicitly? Post-discharge phone calls, and other things that can be done, after hospitalization to make sure the patients are taking their medication safely afterwards. So, the toolkit's designed to be flexible. Whatever you are working on can be improved. Whatever you're not working on can be implemented. Whatever you're already doing perfectly well, you just work on sustaining those. So we've had a gamut of hospitals at different stages in our previous work.
All right, so our next question is, we have a pharmacy lead medication reconciliation team. Our current problem is that sometimes we cannot get admits prior to the hospitalist ordering home meds. What is the best way we can get hospitalists on board to wait for the completion of medication history?
Yeah, that's a great question. I don't think there's any simple answer, but it's all about communication. And we definitely have a number of hospitals where whoever's down in the emergency department taking those histories basically texts or pages the hospital team and says, okay, I'm going to be taking a history on this patient. Please only order the urgent medications that you need to. Hold off on ordering all the chronic home meds until after I'm done with my history. I'll be done by X hour. I think, but you also need to get their buy-in in the first place, right? And again, easier said than done. But if they understand the role, if they understand the process, if they understand that they won't have to reinvent any wheels, they won't have to undo potential mistakes that were made, hopefully they would buy into this. And I think as long as the communication is there. The other thing that we've been working on a lot with sites around their HIT is how do you document this process to make it transparent? Here's the status of the medication history. It's been taken. It hasn't been taken. It was good quality. It was not good quality. You're going to need to fix it later, or you don't need to fix it later. The more communication and documentation and transparency that there is, I think the more likely you can get the hospitalists to wait their turn, do their role, understand everybody else's role, and get this done. And we've seen that in a number of hospitals. And even if the history can't be taken until the next morning, then someone can go see that patient. That can work. As long as urgent medications are sort of dealt with and the rest are dealt with later. So. Happy to talk about that more, but this is exactly the kind of stuff that we talk about on things like monthly office hours. How do you get that to work? So, next question.
Our health system shares one EHR, and refreshing/improving our MedRec process is a priority. Defining standard work, optimizing tools, defining education, defining where dedicated pharmacy resources are needed. Have you had a health system participate in prior collaboratives or only facilities?
Yeah, no, great question. We've had a few health systems do their work across multiple hospitals in their system. Not as many as I would have liked, and some of them ended up scaling back down to one hospital at first. But yes, and I definitely think this is work that can be done across a health system. Especially like you said, if they're all sharing the same EHR, and then working on standard policies, standard operating procedures, how do you get those messages out? So the short answer is yes. I think this is definitely achievable work across multiple hospitals within a health system.
So it looks like we don't have any more questions at the moment. If you do have a question, please type it in or raise your hand. If you think of a question after we're all done here, you're welcome to get in contact either with SHM or Dr. Schnipper via email.
Excellent. And is my email address on one of these slides? I'm trying to remember if it's at the end.
It's on the
there you
question
go. Great.
slide.
Perfect. So feel free to reach out to me. And Sarah, can you remind everybody of the deadlines and the time course that we're talking about?
So the deadline to get the 4700 is February 2019. I am not familiar with what the start and end is for the next wave.
Okay, I think that's when we were going to start the wave. I think it was going to be in February, and just to apologize, the SHM staff member who runs the collaborative is actually out this week, so Sarah has very graciously agreed to substitute in for her, but that's why she's not quite, got that on her fingertips. But yes, I'm pretty sure. No, it's totally fine. Thank you for doing this. Yes, I think we're going to start the wave in February, and I think the applications are due in October. Is that right? But we can clarify that. But you don't need to pay until we actually get started. So that's my understanding of the timeline.
And everyone on the webinar should be getting a follow-up email from SHM's marketing team, and that should have additional information in it.
Excellent. And again, no pressure. But I think we've even getting from Marquis 1 to Marquis 2. I think it was much more successful, and I think we just keep learning more and more the more that we do this. And I think we've gotten a lot of this down. There's very little that I hear at this point that we haven't already seen, and have ideas on how to deal with it. It doesn't guarantee success, but certainly we have a lot of experience to share with everybody, and we think the tools are pretty good. Your hospital has to be committed. That's the one thing that I would say. But if they are, I think a lot of progress can be made. Okay, well, why don't we stop there? Like Sarah said, if you have any additional questions, please let us know. You can email me. You can also contact SHM, and then we'll be in touch with you down the line regarding the specific application, and we can certainly help you with that piece as well. And again, the goal is just to make sure that you're ready to do this. Our goal is not to eliminate a whole lot of sites, but we just want to make sure that it's a good fit. So I think that's it. Sarah, is there anything else you wanted to say before we finish up?
We just had one more question come in, and it says, "Is there a typo on the website, the SHM website, for the next wave starting in February 2018?" I'm not sure if that's when the first.
Ooh, that should say February 2019. Yeah.
Okay.
So, okay, yeah, we'll fix that. I'll clarify it with Megan as well. So, okay, thank you for catching that.
Yeah. All right, then, yeah, I think we're all done, and thank you, everyone, for taking the time to attend.
Excellent. Thank you, everybody. Have a great rest of your day, and let us know what questions you have. So thank you, Sarah, for setting this up.
Of course. Thank you.
All right. Take care, everyone. Bye-bye.